Yeah, do we have the connection? Good. Let's go for it.
We can see you, Ivo. Well done.
Кроснахме още мъничко. Чакам. I will explain you. Just wait a second. No. It's probably better to put the sheet. Yes, of course. Please come to some stand. I will explain you in a second. We have quite good progression. Zoran, wait a little. Everything is good. Good, yes. 8 French, 35. In fact, we have it. Yes. Okay. Okay. So, I will explain step by step. Do you hear me?
Very well.
Okay, excellent. In fact, we are going through the projections, go at around probably 60. And in fact, it was quite difficult. I will explain you why. Because it's an aneurysm, and after the stent graft implantation, in fact, the vessels are relatively far away from the stent graft, because between the stent graft surface and the vessel, there is an aneurysm. And because of that, it's quite difficult to position a catheter and all the telescope system to be really to aim to the stent graft and not to the aneurysm. And because of that, we need catheters and wires and everything to be positioned very precisely. So you can probably observe, go 10 projections back. It was 60, go back to 50. Finally, we succeeded. We changed the wires. And in fact, we succeeded to cross with the electrified wire. That is O18, not O14, but O18. And okay, go back, and I will show you how we crossed. In fact, we did a through and through maneuver with after crossing. I will show you now. Go back, Excellent. Okay, this is the moment of crossing. Go ahead. Like you mentioned, Donald, in 2 projections, we were absolutely sure that we are in the right projection. And this is in fact the moment of crossing the tissue of the stent graft. And this is the wire going into the ascending aorta. This is very crucial to see that the wire is going not outside of the stent, but inside the stent and going to the ascending aorta. And this is the catching the wire by the lasso. Go next. And this is the externalization of the wire. This is the lasso moving through the sheet, through the big sheet. Next. And now you are going to see serial predilation. Go. This is ballooning again. Bigger balloon. Did you see? This is the bigger balloon. Go again. Go. We interchanged the wire. We put a through and through 0.35 wire, and this is the stent implantation. You see? This is the stent implantation. Next. This is the stent, and this is the post-stenting ballooning in order to have the so-called bottle-shaped stent, because of course the trunk is quite a big vessel. And we put a 10 millimeter stent, and we post-dilated with a 12 millimeter balloon outside the graft. Go next. Next, and now I will show the crossing of the left carotid. Up to that moment with the brachiocephalic trunk, and now you are going to see the left carotid. To be fair, for the left carotid, we changed once again the strategy. So the electrified wire resulted not successful, and finally we did the procedure with the needle with the balloon. This is the fourth row balloon from LifeTech. Next. Sorry. I touched, okay, go back a little, back, in order to see, yeah, excellent. Next. Okay, this is the balloon of the fourth row, and this is the wire. Go one back in order to show the needle. One more. Yeah, this is the crossing. In fact, this is the moment of the crossing with the needle. You see the balloon that is in fact centralizing the movement of the balloon. In order, the balloon is inflated inside the vessel, and the balloon is centralizing the axe of the movement of the vector. It's centralizing the vector of the needle. And after that, it's the same. Next, this is catching the wire by the lasso and externalization of the wires. And after that, interchange with the long sheet. This is the wire moved by the lasso, going down to the sheet. And after the externalization and serial predilation, predilation, put the 8 French. Serial predilation, this is the 6 millimeter balloon predilation, and already the tissue of the graft is open, and now we are going to make one more trick that I didn't show to for the brachiocephalic vessel, but I will show the trick with the left carotid. And any questions, comment, something?
No, I think you've explained very clearly what you've done. It must have been a good
Right.
feeling each time that you were able to use the lasso and snare the wire.
Ма дайте, искам с копия, не да тия графии не ни интересуват сега. Okay, we are now crossing. Up. Назад. In fact, we are trying now to cross the whole of the stent graft by the sheet. So the sheet to be through the hole.
Okay, let's take the balloon.
Okay, now
Much safety.
we did the same maneuver.
Let's see.
We are
Advice.
7 millimeter. We are going to put now a 7 millimeter balloon. We are going to put a 7 millimeter balloon, and we are going to use the 7 millimeter balloon as an anchor to cross with the sheet, and under the protection of the sheet, we are going to 0.35. Under the protection of the sheet, we are going to position the stent, the bridging stent. And we were discussing with Professor Stankov, but I think you will agree that it's to shorten the procedure, it's probably a good idea to stop on the level of the two bridging stents to the left carotid and the brachiocephalic trunk. We have, I'm sharing with you now that we have the experience of probably covering more than 400 left subclavian arteries without any significant problem, because after taking a look at the vertebral artery, in case the two vertebral arteries are similar in size, by the Steele syndrome, the left subclavian artery is supplied quite well, quite good, And definitely in order to shorten, hoćete da uradiš? Čekaj. Okay. You see, we are already inside the stent graft. Okay. Give me the stent graft. We are inside the aortic stent graft. And now we are going to position the bridging stent graft. Дърпай водача.
Nemam. Okay.
Дърпай го. Фиксирай го. We are going to use the sheet, the 8 French sheet, as a protection sleeve for the stent graft, for the bridging stent graft. Okay.
Okay.
We are very nicely inside. I'm retracting slowly the sheet and keeping on side the bridging stent graft. I know what you are afraid of. Probably it's not
not.
there.
It's enough.
It's not. Probably you don't breathe as I do. I didn't breathe during that maneuver. You see the indentation of the stent graft,
do,
it's
yes, we do.
excellent. Okay, 8 atmospheres, 10,
10, 10.
Is this a
desinflate.
10? What size is this?
It's a 10 by 57. It's absolutely sufficient for this. In fact, we have measured the carotid artery. It's absolutely sufficient. So we don't going to need any post dilation. And after removing the balloon of the stent graft, we can measure the pressure. Аз ще го измъквам внимателно.
Готово.
А ти
Дръжте.
ти го убираш, да. Okay, excellent. I will measure now the pressure inside the carotid. In case the pressure is good, we are going to remove the bypass. We are going to remove the natural retrograde bypass that we have positioned. Put one, and even more, we are going to, no, this one, it's okay, it's on the pigtail.
Ivo,
Flush, промивка.
why does it have to be so long, the stent into the arch? The left, the one from the left, of course, the right is...
Yeah, I explained already that the aneurysm, in fact, the aneurysm is, so this is the violet. The violet is the carotid. Let me see. Yeah, the violet is the carotid. So this is, the pressure in the carotid is really excellent, absolutely excellent. And let me see, where is the pigtail?
Pigtail in the trunk.
Okay, the pigtail is in the trunk, and we are going to take a look now the aortic pressure. In fact, I will explain you again. Yeah, this is the systemic to the carotid. You see, there is a full overlapping of the curves, and we are done with the carotid, and we can, in fact, most probably we are not going to need any post dilation or something like that. I intend to make an angio, And in case everything is good, we are finishing with the case. And probably we are going to have,
On the left subclavian pressure.
yeah, and this is the subclavian artery pressure. You see the violet is the subclavian. So we have almost 100 millimeters of mercury of the left subclavian. And once again, in order to shorten the procedure, I would suggest to make an angio and to finish. So pigtail and stork wire. And in fact, it would be really excellent for the patient because hopefully you will agree with me, this huge post-operative arch aneurysm was quite risky, and it wouldn't be a good idea to leave behind such an aneurysm without a treatment. Yeah, and okay, we are proceeding now with the pigtail, and in order to have good Congress program, sorry about this huge delay, but you see it's a quite a difficult case. Ако правиш някакви дроби за налягането, не ни трябват. Не правиш нищо. Excellent. So the guy from anesthesiology told me that he doesn't do anything for the pressure. It means we have excellent spontaneous pressure that is around 140. And it's once again telling us that the things are not bad. Not bad. And now we have the pigtail into the ascending aorta. It's fine, super. And now we are going to take a look at everything. Probably we can do some flow into the carotid because we have a sheet in the carotid. And I will improve the flow like we do for the peripheral interventions. Okay. Flushing with saline and preparing for good, hopefully final injection. Ready?
Ready.
Go. Not bad. Not bad. Flow into the carotid and late flow into the left subclavian. Even more, I would suggest probably, hopefully, Zoran will agree with me, we can in fact implant a coil in the ostium of the subclavian artery but it can be done next week, next month, somewhere in the future. And probably let's do one more injection on a right caudal in order to take a look at the bifurcation of the brachiocephalic vessels, of the brachiocephalic trunk.
What size?
And we'll see.
Ivo, what size?
Sorry?
What size on your measurements beforehand was the diameter of the brachiocephalic trunk?
It was 12 millimeter. And
so is that a 12
exactly
millimeter stent that you've placed?
No, 12. We implanted 10 millimeter, and we did it the so-called bottle shape maneuver with 12 millimeter post dilation of the stent, but outside the graft. So the whole inside of the graft is 10, and outside the graft is the proximal part is inflated by 12. Ready for the injection?
Yes.
Go. I think it's useless. No,
Yeah.
So, yeah, we don't need second stent, and the aneurysm is not filled at all. It's zero filling of the aneurysm.
Yeah, it looks much better.
And what is your opinion?
I think it looks much better on this view, Ivo. I was concerned about the sizing of the brachiocephalic trunk and the filling of the left subclavian, but the brachiocephalic trunk seems to be perfect. And
I will
can-
show you
can
now,
go back for any
like we
reason
do.
on the left
Pass.
subclavian.
Yeah, we can do everything.
Yeah,
We
you
can
even go
do,
back and do the same thing as going through if there was a
Yeah, we
problem
can
with
do
flow.
secondary. We can do secondary, Kamnego. We can do secondary procedure, several secondary procedure. And now I will show you the still phenomenon, how is feeling the subclavian artery by the vertebrals. Okay, waiting. And seeing the left vertebral in the late phase, the left vertebral is quite optimal filled. Carotid phase and now vertebral phase.
And subclavia.
And the opacification of the left vertebral artery. Okay,
Fantastic, Ivo.
Amazing results, Ivo. So you've done a complete aortic arch reconstruction
yes,
percutaneously.
thank you. You probably can see the overlapping curve of the pressure. So we have optimal result for both carotids and everything else. And in fact, I will change myself and I will join you for the program, and I will leave Professor Stankov to do the.
Thank you so much. It's a pleasure for me. One Manta, one Prostyle,
I trust you.
couple of Angiostil.
Okay, thank you guys.
Don't worry.
Thank you guys. I'm practically ready to speak for the SWIX symposium, and during the speeches of Professor Postajian and Velchev, I can drive to the Congress Hall.
Thank you very much. That's super.
So